Good morning, friends. Yesterday's day was very much non-studying day. Yesterday, I have just completed respiratory physiology part one and uh, whatever. So today, my target will be respiratory physiology part two. Respiratory physiology part two, cardiovascular physiology. From here, gastrointestinal to the regulation of body temperature we have done. So this 1, 2, 2, 3, 4, and these two optional. These two targets are optional. We have to done 1, 2, 3, 4. 3, 4. CVS recipe part 2, neurophysio 1 and 2. No muscle and general cellular is optional. Let's go. Time is 10:48. I am very late because in night I can't study, but I can't sleep also. So I slept at around 1:30 a.m. I think, and morning I wake up around 10 a.m. So yes, I am late, but let's go. See, we have 1 hour for 12, and let it make one, so 2 hours, and then after lunch we have 2 to 3, 3 to 4, 4 to 5, 5 to 6, 4 hours. So we can easily complete our whole physiology today, one read, and not just only read, but we can also understand it and try to memorize it. So far till now, अब तक हमने एनाटॉमी आधा अधूरा टूटा फूटा जैसा, फार्मेकोलॉजी और फिजियोलॉजी अब ख़त्म करेंगे. So this is my 12th day, I think. I don't know. Last upload I didn't do. Yes, so this is my 12th day of Neet PG preparation, and it's been around a month from last my Neet PG attempt. Let's go, guys. Let's go. Subscribe to my channel who wants to just study with me. Subscribe, guys, and just subscribe to my channel and just start it. बस रुको मत किसी के लिए भी पढ़ने के लिए, बस चालू कर दो. आज का अपना टारगेट ये पूरा फिजियोलॉजी ख़त्म करने का है. 10:50 हुए और अभी चालू करते हैं. चालू तो वैसे हमने कब का किया हुआ है, 3 मिनट हो चुके हैं. चलो.
This arterial blood, 40 millimeters of mercury corresponds to a volume of 48 ml. That means what? This 52 ml minus 48 ml. The difference is 4 ml of carbon dioxide usually transported per 100 ml of blood. That's all. Very simple. Venous carbon dioxide partial pressure 45. Volume of CO2 in venous blood 52 ml. Arterial blood CO2 partial pressure 40. Here the volume of CO2 is 48 ml. So this 52 ml minus 48 ml, the difference, usually it is the 4 ml of carbon dioxide that is transported by 100 ml of blood. This is about carbon dioxide dissociation curve. Right guys, in respiratory physiology, we discuss so much of functional aspects. Now we are going to regulate all of them. This is regulation of respiration, two modes of regulation, neural regulation, chemical regulation. First we are going to discuss about the neural regulation, which means brain areas. Where the brain areas are located. Simple, it is present in pons, it is also present in medulla. In pons we see two group of neurons. In medulla, we see three group of neurons. What are the pontine neurons? In upper pons, we have pneumotactic center. In lower pons, we have apneustic center. That means upper pons, pneumotactic. Lower pons, apneustic center. What about medulla? Three important locations, medulla. If it is seen in the dorsal side, we have dorsal respiratory group. Seen on the ventral side, ventral respiratory group. On top of ventral respiratory group, you have very
Start studying, guys. Just don't wait for anything.
The pacemakers for respiration, pre-port finger complex. So the medulla three neurons are DRG, pre-port finger complex. Why they are there? What functions they perform? Pre-port finger complex, I told you, is considered to be the pacemaker. Pacemaker means respiration initiation. This is the most important concept. Initiation is possible because of pacemaker, pre-port finger complex. Pneumotactic center, the normal function is to limit inspiration. Apneustic center, the
Regular
normal
accounts,
function is to
phones.
prolong inspiration. How pneumotaxic center is going to limit inspiration? By inhibiting our apneustic center. Most important concept. Pneumotaxic center will inhibit apneustic center, thereby limiting the inspiration, because the normal function of apneustic center is always to prolong inspiration. Which important area is going to regulate or control the respiratory rate of inspiration? Pneumotaxic center is going to control the respiratory rate. That's all. Pneumotaxic center limit inspiration, control respiratory rate. Apneustic center prolong inspiration. Normal pneumotaxic center inhibit apneustic center. Simple. Now what about medulla, sir? Useful mnemonic is time. That means dorsal group is for inspiration, ventral group is for expiration. What is this DRG going to do, sir? It will exactly generate a signal like this. What is
Ramp
this signal
signal.
called? This signal is called
Ramp signal.
DRG. This is needed for smooth increase in tidal volume.
Ramp signal.
Ramp signal is generated by DRG, inspiration for smooth increase in tidal volume.
Smooth
What
increase
about
in
ventral
tidal.
respiratory groups, sir? Especially during exercise. What are we going to get? We are going to see the forceful expiration. It is this forceful expiration during exercise that is controlled by ventral respiratory group. So type dorsal for inspiration, ventral for expiration. Exclusively the ventral respiratory group during exercise, control of forceful expiration. So which neurons are the pacemakers? Three-hot singer complex. Where will you see ramp signal? Dorsal respiratory group. During exercise, who functions better? Ventral respiratory group. Now, these critical areas, what will happen when there is a lesion? First lesion point, A, that is above pons. Any lesion above pons, respiration totally remains normal, no problem at all. Because below pons, all the areas are intact. So respiration functions normally. What is this lesion point B? This lesion point B is
Above.
mid-pontine lesion.
So
If the
respiration
vagus is
is
wet, what will
normal.
happen? Mid-points means this pneumotaxic center no longer inhibit apneustic center. Mid-pontine lesion, pneumotaxic center can no longer inhibit apneustic center. So automatically there will be prolongation of inspiration. Yes. Mid-pontine lesion with vagus cut, there will be prolongation of inspiration. What is the lesion point C, sir? Between pons and medulla, pontomedullary junction, our respiration begins.
So here at mid-pontine level, if vagus cut, what does mid-pontine level indicates? કે ઉપર છે ન્યુમોટેક્ટિક અને એપન્યુસ્ટિક, બરાબર. હવે એ બે છે એકબીજાને સિગ્નલ નહીં આપે. એપન્યુસ્ટિક છે એ પ્રોલોંગ ઇન્સ્પિરેશન કરાવતું હતું, એ નહીં કરાવે, બરાબર. તો વેગસ કટ તો એપન્યુસિસ થશે. એપન્યુસ્ટિક સેન્ટર છે, એપન્યુસિસ કરશે, બરાબર છે. બ્રીથ હોલ્ડ ઇન ઇન્સ્પિરેશન, પ્રોલોંગ ઇન્સ્પિરેશન જેવું થશે. વેગસ કટ થશે તો ઇફ વેગસ પ્રિઝર્વ then ડીપ બ્રીથિંગ થશે. વેગસ પ્રિઝર્વ થઈ ગયો છે તો ડીપ બ્રીથિંગ થશે. વેગસ કટ છે તો પ્રોલોંગ ઇન્સ્પિરેશન. ઓકે.
Becomes irregular, very important. Pontomedullary junction lesion, respiration becomes irregular. What will happen, sir? The critical lesion, that is lesion below medulla. That means you are interrupting our pacemaker, Mbbs complex. No impulse can go down to spinal cord. That means respiration will stop. Death is inevitable. So above pons means respiration remains normal. Below medulla, no respiration. It stops. Then mid-pontine lesion will
એપન્યુસ્ટિક સેન્ટરનો કંટ્રોલ ક્યાં જ જતો હતો? ડોર્સલ ગ્રુપથી આવ્યો. ડોર્સલ ગ્રુપ શું છે? ઇન્સ્પિરેશનને કંટ્રોલ કરે. તો એપન્યુસ્ટિક સેન્ટરને કંટ્રોલ કરતો તો ડોર્સલ ગ્રુપ. વેન ડોર્સલ ગ્રુપ કટ, એપન્યુસ્ટિક સેન્ટર ઓલ્સો કટ. ઇરેગ્યુલર ઇન્સ્પિરેશન. જો અહીંયા બરોબર હશે, અહીંયા એપન્યુસ્ટિક સેન્ટરની ઓવર એક્ટિવિટી થઈ જશે તો પ્રોલોંગ ઇન્સ્પિરેશન. પછી એની નીચે રેગ્યુલરાઇઝેશન એબસેન્ટ, રેગ્યુલર ને ઇરેગ્યુલર એવી રીતે, અને અહીંયા તો ડેથ જ છે. ઓકે, ડન.
the vagus cut prolongation of inspiration, pontomedullary junction, the respiration becomes irregular. Yes. As a part of neural control, we need to understand certain reflexes. Herring-Brewer reflexes, first and foremost, remember guys, in Herring-Brewer inflation reflex, the inspiration will be inhibited. In Herring-Brewer deflation reflex, the expiration will be inhibited. That's all. In Herring-Brewer inflation, inspiration is inhibited. In Herring-Brewer deflation, expiration will be inhibited. First, inflation reflex. The normal stimulus here.
Prevent injury. ઓકે, સો આમાં ઇન્હિબિટ ઇન્સ્પિરેશન છે. ઇન્ફ્લેશનમાં ઇન્હિબિટ ઇન્સ્પિરેશન, ડિફ્લેશન ઇન્હિબિટ ડાય. I, die. DI, die. ઇન્ફ્લામેશન માં એક્સપાયર કરશે તો ઇન્સ્પાયર નહીં કરે. ડિફ્લેશન ઇન્સ્પાયર કરશે તો એક્સપાયર નહીં કરે. જો ઇન્ફ્લેશનમાં ઇન્હેલ કરે તો એને કહેવાય પેરાડોક્સિકલ રિફ્લેક્સ ઓફ હેડ. લંગ ઇન્ફ્લેશન થશે, પલ્મનરી સ્ટ્રેચ રિસેપ્ટર સ્ટિમ્યુલેટ થશે અને ઇન્ફ્લેશન થશે લંગનું. રિસ્પોન્સ ફોર ફર્સ્ટ બ્રીથિંગ. ઓ તો ફિઝિયોલોજિકલ છે. Physiologic. Nice.
That is the overstretch. For example, the tidal volume of 1500 ml. Prolonged expiration, whenever there is prolonged expiration, further inspiration will be inhibited. That's all. Overstretch is the stimulus. Tidal volume of 1500 ml. The receptor is the pulmonary stretch receptors. They are slowly adapting. The afferent is very important. They are large fibers. They are myelinated fibers of
large
myelinated
myelinated fiber.
The afferent information is conveyed to large myelinated vagal fibers. I told you, in inflation, inspiration will be inhibited, so automatically expiration commences. So Hering-Breuer inflation reflex means inspiration will be inhibited. In Hering-Breuer deflation, look carefully, if you keep on expiring, at one point of time, there is possibility of alveolar collapse. That is why this deflation reflex is mainly to prevent reflex of which alveolar collapse. That means if I keep on expire, at one point of time my alveoli may collapse. To prevent alveolar collapse, there is Hering-Breuer deflation reflex where expiration is inhibited. You can clearly see decreasing duration of expiration. That means expiration will be inhibited here. It is the same large myelinated vagal fibers. The afferent for Hering-Breuer reflexes is same. In inflation reflex, expiration is inhibited. In deflation reflex, expiration is inhibited. What is the afferent? Is a large myelinated vagal fibers. We have a paradoxical
Obvious.
What is the meaning of this
Hering-Breuer
paradoxical? The
reflex
stimulus is
coming out
against the
of
lung
the
inflation. Here paradoxical means increase in lung inflation is going to increase further inflation. That means increasing expiration keep on increases further expiration. This is paradoxical to which reflex. Look very carefully. In Hering-Breuer inflation, further inspiration will be inhibited. In this paradoxical reflex, it is called paradoxical because increasing inflation keep on increasing further inflation. This happens when the infant takes the first breath. When we all born to this world, our lung is filled with the fluid. To replace that fluid with air, you keep on expire more and more air goes inside, so fluid will be expelled. So increasing inspiration, keep on increasing further inspiration is paradoxical reflex of head. Increasing inspiration, increasing further inspiration. That is why it is paradoxical reflex of head. And finally we have J reflex, where the stimulus is pulmonary congestion. You classically see this in pulmonary edema, J receptors. They were actually discovered by an Indian Avtar Singh Paintal, an Indian physiologist. J receptors, AS Paintal. They are stimulated during pulmonary congestion. You see in pulmonary edema, the receptors are the juxtapulmonary receptor. Here is what is most important. The afferent are going to be unmyelinated, very important, vagal fibers. So for Hering-Breuer, it is myelinated vagal fibers. For J receptor reflex, it is unmyelinated vagal fibers. The effect is going to be rapid breathing, bradycardia, hypotension. These are all you classically see in pulmonary edema patient because of stimulation of J receptor. The afferent is very important, unmyelinated vagal fibers. For Hering-Breuer, myelinated vagal fiber. For J receptor reflex, unmyelinated vagal fibers. These are the reflexes. In all certain alveolar breathing patterns, we call them as periodic breathing pattern. To understand them, first look into the normal respiration. Normal respiration, we call this as normopnea. Quickly compare this with the periodic breathing. What are we classically seeing? We are classically seeing a periodic breathing pattern like this. We call this as waxing, waning. Waxing and waning. The sequencing here is hyperpnea, hypopnea, apnea. Hyperpnea, hypopnea, apnea. What is the sequence, sir? Waxing and waning breathing, Cheyne-Stokes respiration. This is normally seen during sleep, remember. Pathologically, it is seen in congestive cardiac failure and also in patients suffering from pneumonia. Waxing and waning type of breathing is a periodic breathing, Cheyne-Stokes respiration. Hyperpnea, hypopnea, apnea. Normally seen during sleep, pathologically in congestive cardiac failure during Cheyne-Stokes respiration. Now look into this breathing pattern. What are we observing? It is only hyperpnea, apnea. Hyperpnea, apnea. There is no hypopnea. What is this breathing pattern? Biot's breathing. You classically see this to injury to medulla and also in patients suffering from meningitis. Okay. Biot's breathing, Hyperpnea, apnea. Hyperpnea, apnea, this cycle. Injury to medulla, many things. Particularly in diabetes patients, what we see is small respiration. It's also called as acidotic breathing. You mainly see this in diabetes. There is classically increase in rate of respiration, increase in depth of respiration. So rate is also increased, depth is also increased. It is a type of hyperventilation. It is a type of hyperventilation seen in diabetics, both rate and depth increasing here, acidotic breathing, diabetics, which is also called Kussmaul's breathing pattern. So these are all the things you need to remember for neural control. Now we are moving into chemical control. What are all the chemicals going to regulate our respiration? Only 3 chemicals. It is going to be oxygen, it is going to be carbon dioxide, it is going to be H plus ions. These chemical changes will be sensed by chemoreceptor. Where they are located, sir? In brain means we are going to call them as central chemoreceptor. Other than brain, particularly in the neck region, we are going to call them as peripheral chemoreceptors. So the chemical sensing chemoreceptors in brain, it is central chemoreceptor. In the neck region, it is peripheral chemoreceptor. How they function, sir? Look very carefully. Now this is about the central chemoreceptors. Very important. Suppose in the brain blood vessel, carbon dioxide level rises. This carbon dioxide can easily cross the blood-brain barrier. Very important. Inside it comes in the CSF, what is going to happen? It reacts with the water. In the presence of carbonic antibase, we form carbonic acid, which splits into H plus ion and a bicarbonate ion. So from carbon dioxide, we are generating a H plus ion. It is this H plus ion which is going to stimulate my central chemoreceptors. Very important. So who is actually stimulating my central chemoreceptors? H plus ion. Two important type of questions. Our central chemoreceptors are sensitive to, it is sensitive to partial pressure of carbon dioxide in blood. It is sensitive to partial pressure of carbon dioxide. But who is actually stimulating the chemoreceptors? H plus ions in the CSF. Do you able to understand that? Central chemoreceptors are sensitive to partial pressure of CO2. But they are directly stimulated. By H plus ions in the cerebrospinal fluid. Simple. Right, guys. From central chemoreceptors, let's shift our attention to peripheral chemoreceptors. Where are they located? In the neck region, in the form of bodies, carotid bodies and aortic bodies. These peripheral chemoreceptors, low partial pressure of oxygen, hypoxia. Quickly compare. Central chemoreceptors, carbon dioxide. Peripheral chemoreceptor, low oxygen, hypoxia. How they are going to sense this? They have certain oxygen sensors, which are
Hello, 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 hello.
are called as glomus cells. Important name. Peripheral chemoreceptor, oxygen sensor, glomus cells. In response to hypoxia, what will happen? The same mechanism we discussed in lung, remember? There is always an oxygen-sensitive potassium channel. In response to hypoxia, they close. Because of this closure, potassium accumulation, depolarization. Depolarization opens which channels? Calcium channels. What this calcium is going to do here? Release of neurotransmitter. Dopamine. Because of this dopamine, it is stimulating the afferent nerve ending, so the signal of hypoxia goes to brain. That's all. Peripheral chemoreceptors in carotid bodies and aortic bodies, they are sensitive to hypoxia. They have oxygen sensor glomus cells. In response to hypoxia, potassium channels closes, leading to depolarization, which opens calcium channel, release of neurotransmitter dopamine, stimulating afferent nerve fiber. The information of hypoxia is going to brain. That's all. Now we discussed about central chemoreceptors and peripheral chemoreceptor. Now, consider this individual where all the stimulus are present. Choline PO2, hypoxia. Rising PCO2, rising H plus ion. So all these 3 stimulus are present. That means what? This state is called asphyxia, which is going to stimulate both the central and peripheral chemoreceptor.
Fall in
See, this hypoxia
PO2,
stimulate peripheral chemoreceptor.
fall in PO2, rise in PCO2 and acidosis. Fall in PO2, rise in PCO2 and acidosis. Central and peripheral chemoreceptor both. क्योंकि increase CO2 will stimulate central, decrease PO2, hypoxia will stimulate peripheral.
H plus ions CO2 they stimulate central chemoreceptor. So in asphyxia, both the central and peripheral chemoreceptors are activated. When they are activated, they lead to a reflex that is called the chemoreflex. The basic effect of this chemoreflex is hyperventilation. That's all. So asphyxia, the patient who is suffering will have hyperventilation because of chemoreflex. When both the chemoreceptors are stimulated, you will get chemoreflex. The effect of the chemoreflex is hyperventilation. You classically see this in patients suffering from asphyxia. That's all. Now, as a part of this chemoreceptors control, you also need to understand certain types of hypoxia. What are the type of hypoxia, sir? 4 important types. One question, sure shot. What are these 4 types? Hypoxic hypoxia, anemic hypoxia, stagnant hypoxia, histotoxic hypoxia. What it is due to, sir? Hypoxic hypoxia means low partial pressure of oxygen. Anemic hypoxia means very simple. It is the reduced oxygen content. This point is very important. Here VO2 remains normal in anemic hypoxia, but what is actually reduced? That form of oxygen combining with hemoglobin, that is oxygen content. Reduced oxygen content means anemic hypoxia. Reduced blood flow, that type of hypoxia is stagnant hypoxia. And finally, histotoxic hypoxia means decrease in oxygen utilization. If oxygen is not properly utilized, then also it leads to hypoxia, histotoxic hypoxia. So arterial VO2 is reduced only in the hypoxic hypoxia. It is remaining in normal arterial VO2. Arterial VO2 is decreasing means mainly it is hypoxic hypoxia. Next point. Hemoglobin content will be reduced only in anemic hypoxia or oxygen content. Oxygen content, hemoglobin content, it will be reduced in anemic hypoxia. So low VO2 means hypoxia. Reduced oxygen content means anemic hypoxia. Peripheral chemoreceptors are stimulated in all the types except anemic hypoxia. Basically because if VO2 remains normal, peripheral chemoreceptors are not stimulated. So peripheral chemoreceptors are not stimulated in anemic hypoxia. For example, hypoxic hypoxia you see during high altitude, you see in patients suffering from COPD. Anemic hypoxia, classically you see in anemia, not only that, this important poisoning, carbon monoxide poisoning. Stagnant hypoxia, you see in any clinical condition characterized by ischemia. Histotoxic hypoxia, mainly during this poisoning. Remember, cyanide poisoning, very important. So they will ask you, carbon monoxide poisoning, anemic hypoxia. Cyanide poisoning, histotoxic hypoxia. High altitude, hypoxic hypoxia. Low partial pressure of oxygen, hypoxic hypoxia. Reduced oxygen content, anemic hypoxia. Peripheral chemoreceptors are not stimulated, anemic hypoxia. Like this, they can pick any number of questions from this table on types of hypoxia. Alright guys, now we are going to revise environmental physiology. 3 important environment. High altitude, deep sea, space. These 3 environments. First, let's look into high altitude. What is the basic problem in high altitude? We have to tackle hypoxia. To tackle this hypoxia, we have certain compensatory changes. What are these compensatory changes, sir? Immediately, this hypoxia is going to stimulate peripheral chemoreceptors. There will be increase in respiratory rate, leading to carbon dioxide washout. Carbon dioxide is washing out means fall in H plus ion. This leading to a state like alkalosis. What is this alkalosis? This alkalosis is because of respiration. We call this as respiratory alkalosis. See guys, there is a common binding protein, albumin, for H plus ions and calcium. When there is respiratory alkalosis, when there is low H plus ion, more amount of calcium can bind to albumin. Understand? Low H plus means there is no competition for calcium. Lot of calcium are coming and binding to albumin. So which form of calcium rises? The bound form increases calcium. So what happens to the free form of calcium? It decreases. It is the free form of calcium responsible for all the actions. If the free form is decreasing, they are more prone for a very important state. We call this as hypocalcemic tetany. Simple. What I told you? Because of respiratory alkalosis, the bound form of calcium is increasing. The free form of calcium is decreasing. Decrease in free form, all the actions of calcium will be lost. We get hypocalcemic tetany. This is a very important point you have to consider. In high altitude, respiratory alkalosis is possible. Hypocalcemic tetany is possible. Other than that, hypoxia is going to stimulate erythropoietin. Obviously, there will be increase in RBC. Hypoxia also stimulates vascular endothelial growth factor, which is going to stimulate blood vessel formation. We call that as angiogenesis. Because of this angiogenesis, there is increase in vascularity. Very important. The same hypoxia. Stimulating erythropoietin, increase in RBC. Stimulating vascular endothelial growth factor, angiogenesis, increase in vascularity. And finally, also remember the oxygen dissociation curve. Remember, in high altitude, it will be shifted to right side. So what all we have seen? Erythropoietin increasing RBC, vascular endothelial growth factor promoting new blood vessel formation, and oxygen dissociation curve shifting to right side. The individual is going to high altitude. Right. Next. Let's go deep into the sea. What is the basic problem, sir? Going into the sea. It's about the high barometric pressure. Because of this high barometric pressure, gases are compressed. Imagine having a soft drink bottle, okay, soft drink bottle. Gases are compressed. If you try to open it, the gases will come out as bubbles. This is what exactly I'm telling. When they undergo decompression, this gases leads to bubble formation. And that gas we are predominantly interested is the nitrogen bubbles, which at times going to turn into toxic. So when the gases undergo decompression, they are released as bubbles, out of which nitrogen is most important. That is why the individuals are more prone for a sickness that is called decompression sickness because of release of nitrogen bubbles. What is the other name for this disorder, sir? Jason's disease. Remember, it is none other but a form of decompression sickness. Yes, Jason's disease seen in Jason workers. Importantly, gas bubbles. It is about the nitrogen bubbles. This nitrogen can easily cross the blood-brain barrier, so they are more prone for something called as nitrogen narcosis. Jason's disease, nitrogen crossing blood-brain barrier, there is nitrogen narcosis possibility. Next, the joints will have pain. We call them as pains. Bubbles occluding lungs. Chokes are common. This disease is also called bends and chokes. Most importantly, this nitrogen bubbles occluding blood vessel can cause air embolism, turning fatal, leading to death at times. So what is the common cause for death in Jason's disease? Nitrogen bubbles occluding latent blood vessels. For example, in descending thoracic aorta, if the bubbles are occluding there, air embolism, death is inevitable. So what is this disease? Jason's disease. Now, let's explore the space where we have to give importance to gravity situation. Positive G, negative G. What is this, sir? In positive G, a huge gravitational force is acting from head to foot. But I'm telling acting from head to foot. First step, here in positive G, it is from head region to foot region. Because of that, all the blood is now pushed to the foot region. What will happen? In the lower limb, there is venous pooling. Because of this venous pooling, cardiac output decreases because no blood is coming to the heart. They are pulled in the periphery. If cardiac output decreases, cerebral perfusion decreases. This individual will develop unconscious attacks because of decrease in brain blood flow. We call this as blackout phenomenon. Positive G, from head to foot direction, venous pooling, reduced cardiac output, reduced brain blood flow, unconsciousness, blackout. Positive G. What about negative G, sir? Exactly opposite. Here, it is acting in the opposite direction. What is that, sir? From foot to head. From foot to head, opposite. Negative G. So what is the gravitational forces from foot to head? Because of this, there is increase in venous return. Yes, there is definitely going to be increase in venous return. Because of the cardiac output increases, you can clearly say cerebral perfusion increases. That means particularly in the eyes, there is congestion. Very important. So much of blood is going from heart to brain, filling in the eyes, more blood in the eyes, congestion. What we classically see here, red out. Red means congestion. So positive G, blackout. Negative G, it is the red out. Simple. So many people are going to space what they commonly encounter, what they commonly experience if there is a prolonged stay there. Look carefully, guys. Definitely there is going to be loss of calcium and phosphate from their bones. So whoever goes there, big salute to them because they have to face all of this. Loss of calcium, loss of phosphate, leading to loss of bone mass, highly susceptible to fractures. RBC number decreases. Because of that, if they stay for prolonged duration, overall their performance means work capacity, remember, decreases because of all this thing. Loss of calcium and phosphate, loss of bone mass, decrease in RBC number. Eventually, because of all of this, their work capacity, their performance decreases. This is about the effect of microgravity. Who was staying for long period in space, their work capacity decreases. So respiratory physiology, along with that, we covered environmental physiology. You would have seen definitely a high possibility for so much of MCQs. Please to revise it, guys. Good luck and best wishes.
તમે તો કીધું તો પણ એનું મેં શું કરવું હવે. Now we end this session and come after, I think. Oh, there is one live बंदा. भाई 10 से 15 मिनट में वापस आएगा लाइव. गयो